Welcome to the basic cardiac, lung, inferior vena cava assessment with ultrasound presentation. Real-time ultrasound use as a diagnostic tool has revolutionized the way we approach and manage critically ill patients, and we are thrilled to share this knowledge with you. This presentation is specifically designed for those of you who may have minimal or no experience with ultrasound. We understand that ultrasound technology can seem daunting at first, but don't worry. This presentation was created with the novice learner in mind, breaking down complex concepts into digestible information. Before we dive into the specifics, we assume that you already have a basic understanding of an ultrasound machine. Our goal is to ensure you walk away from this presentation feeling confident and ready to apply these skills in your practice. The objectives of the presentation are to introduce the four primary views of the heart, including the peristernal long axis, the peristernal short, the apical four-chamber view, and the subxiphoid view. Want to understand just basic heart function, global heart function. We're not trying to identify exactly what an ejection fraction is or getting into valve disorders. We're just trying to identify, is this heart good, bad, or hyperdynamic. I want to talk about the concept of estimating fluid volume status using inferior vena cava assessment, and then introduce the concept of pulmonary A lines and pulmonary B lines. So when will you use this in critical care? Well, this isn't an all-inclusive list, but things that I can think of off the top of my mind are the hypotensive patient. You're trying to figure out, is this cardiogenic shock? What's the volume status? How's the heart contraction? So it's very helpful with the hypotensive patients. Cardiac arrest, sometimes there's a question, is the heart contraction? Well, with the probe, you can just put it on the chest and look. Post-arrest, to evaluate for some of the H's and T's, in particular, plus minus hypovolemia. If you look at the IVC and it's clearly collapsing, yes, maybe they're in hypovolemic shock. Could also be distributive shock. Definitely can look for a pneumothorax. Take a pneumothorax off of the table. You can look for cardiac tamponade. Plus or minus pulmonary embolism. You can see right-sided heart dilatation or high right-sided pressures with the ultrasound machine. Maybe not see a thrombus in the coronary artery, but you can look at global heart function, and those with advanced ultrasound education can actually look at the cardiac wall and look for motion abnormalities. Probably not going to help you with hypoxia, hydrogen ion, hypokalemia, or any of these things over here, but you can rule out some things during a cardiac arrest or post-arrest. And then with the dyspneic patient, easy to evaluate for pneumothorax. You put in a line, your patient's decompensating after the line. Rather than waiting on a chest x-ray, you can just look and tell if the lung's up or down. Decompensating ventilator patient, and then one of the things in the differential for dyspneic patient is volume overload, and you can look at the lungs in combination with the heart and kind of help figure out whether the patient's in flash pulmonary edema. A lot of what we'll talk about is ideal positioning and ideal images that you'll get with ultrasound. However, I realize that most often the patients look like this over here, and we don't have ideal positioning. That said, most of what's needed in ultrasound can be done even when your patients look like the image on the right. So the probe you're going to want to use is the phased array. The phased array allows you to work between ribs when you're looking at the heart. You can't get the subxiphoid view with the curvilinear probe or the convex probe, and you can do lung sliding with the linear probe. However, all tasks you need done in critical care can pretty much be done with the phased array. So if you're choosing one probe, I would choose the phased array probe. A reminder about orientation. So abdominal mode, when your ultrasound machine is in abdominal mode, the indicator will be on the left. When you're in cardiac mode, the image indicator will be on the right. The image will look the same if done properly. However, your orientation of the probe will be 180 degrees depending on which mode you're in. So I'm going to teach you both. When I first learned the abdominal mode, but I think cardiac mode allows for a little better image when you're looking at the heart, so we'll talk about both of them. One of the things I've seen new learners struggle with is getting the indicator in the probe position correctly. So the way I like to teach it is start at the peristernal long axis view and work your way clockwise. So what's that mean? It means you really just have to memorize where to start, and that's the peristernal long axis view. We'll go over all of these. But if you're in abdominal mode, the goal of the peristernal long will be to get the apex of the left ventricle on the left-hand side of the screen. So we'll start with the indicator pointed at the 5 o'clock position, do a 90-degree turn to the right. For the peristernal short, we'll get the apical forechamber, and then we'll get the subxiphoid. After that, you'll make one more turn, and you'll get the IVC. If you're in cardiac mode, that's fine. The moves are the same. However, you start with the indicator at the 11 o'clock position. You still make a 90-degree turn to the right for the peristernal short. Come right down for the apical forechamber. Move over for the subxiphoid. Another 90-degree turn for the IVC. So your move is start at the peristernal long, peristernal short, apical forechamber, subxiphoid, IVC, and we'll go over all of those. This is a general overview of the entire exam. The first image, the peristernal long, actually this image will give you a lot of information, and often this is the only image you need. But the goal here is to get the apex on the left side of the screen, and we are with our sound waves coming this direction, so this plane here. To do that, it doesn't matter what mode you're in, abdominal or cardiac. So if you're in abdominal mode and the indicator is on the left side of the screen, the indicator will go here at the 5 o'clock position. If you're in cardiac mode and the indicator is on the right side of the screen, we still need to get the apex on the left, so we do a 180-degree turn and the indicator is in the 11 o'clock position. So once we get this view, turn to the right, 90 degrees, get the peristernal short, apical forechamber, subxiphoid. Peristernal long, 90-degree turn to the right, peristernal short, come over, apical forechamber, and then the subxiphoid. You don't need to get all 4 views. A lot of times just the peristernal long is all you need, and then the subxiphoid. I usually use the subxiphoid when I have a lot of gas in the chest. Sometimes the subxiphoid is the only view that can be obtained. So the first in the series is the peristernal long. Again, our goal will be to get the apex of the left ventricle on the left side of the screen. To do that, indicator is either going to be 11 o'clock or 5 o'clock. The peristernal long axis view. So abdominal mode is on the left, cardiac mode would be on the right. Here, we know we are in abdominal mode. Our goal is to get the apex of the left ventricle on the left side of the screen. So in abdominal mode, we put the indicator over where about the apex is. And this is how the image is going to look. Left atria goes into the left ventricle, aortic outflow tract. This is the anterior leaflet of the mitral valve. These are the papillary muscles. Think of this as the right side of the heart. So depending on where the probe is, it's either the right ventricle or the right ventricular outflow tract. This is the descending thoracic aorta. Again, image on the left with the apex on the left side of the screen, regardless of what mode you're in. This happens to be in cardiac mode. We know that because the indicator is on the right-hand side. However, the image looks the same. So the apex is on the left side. LA, going into the LV, the aortic outflow tract, anterior leaflet of the mitral valve, these are little papillary muscles here, descending thoracic aorta. Kind of hard to see up here, but this is the right ventricular outflow tract. The parasternal short axis. Again, we come off of the parasternal long, make a 90-degree turn to the right. With the indicator pointing this way, we know we're in a cardiac mode. If you were in abdominal mode, you would just be 180 degrees to that. The key thing here is the LV should be on the right side of the screen, and the RV should be on the left side of the screen. I'll show you. So for the parasternal short axis, there are several cuts that you can do with the parasternal short. I would say when you're first learning, just do one and go from there. With the parasternal short axis, again, the LV is going to be on the right side. The RV is going to be on the left. We know this particular image is in cardiac mode because of the way the indicator is. As your ultrasound skills improve, with this view, you can look at the particular walls of the heart. So this would be the septal wall, the anterior wall, the lateral wall, and the inferior wall. This is the mitral valve here. And when you're first starting it out, you're not assessing this. You're kind of just looking at size and global general function. Here's the parasternal short at the level of the papillary muscle. Again, when you're first learning, just look at LV, RV. This is the parasternal short at the aortic valve. Okay, so you've done the parasternal long, 90-degree turn to the right. You get the parasternal short. Now you come from the parasternal short to the apical forechamber. Depending on which mode you're already in, the indicator will be opposite. The apical forechamber in cardiac mode has the indicator to the right, and abdominal mode will have the indicator to the left. This is how the apical forechamber will look when you capture the image. LV, LA. This is the mitral valve, the RV, the right atria. So left ventricle, left atria, right ventricle, right atria. This image happens to be in cardiac mode. After the apical forechamber, the indicator is staying in the same general direction, and you come from the apex and just move under the subxiphoid. I have found the way that works the best. If you watch the EFAS lecture, you can roll through the liver to see the heart, I have found if you just kind of visualize where the heart is, pretend your probe is like a flashlight and try to shine the light on the heart, generally it will come into view. This is how the subxiphoid or subcostal view will look. Again, think about what side of the heart is closest to the probe. Here is the RV, the right atria, the left ventricle, the left atria. Worry about valves later, but this is the mitral valve. This is the tricuspid valve. RA, RV, LA, LV. I want you to just look at these images as they pop up and ask yourself which hearts look like they're pretty strong and which hearts look like they're pretty weak. If you're giving somebody a fluid bolus, which heart would you be more concerned about giving? And I think watching these, you can kind of tell that this is not rocket science. Again, when our goal is not figuring out exactly what the valves are doing or what the ejection fraction is, we're just looking at global heart function. And for me, when I see a heart that's hyperdynamic like this, or a heart like this, I'm less concerned about giving them 500 or a liter bolus of fluid than I am when I see a heart looking like this, who is maybe already on a lot of oxygen. These hearts are globally weak. So hyperdynamic on the right, this is the peristernal long axis view on the top, and then the subxiphoid on the bottom. Some findings of obstructive shock or potential findings you might see. So this is the peristernal long up here. This is hypertrophic obstructive cardiomyopathy. So you see a big large septum here. This is the RV, the LA coming into the LV, the aortic outflow tract. So Holcomb is a possibility. And then a fairly common finding is either pericardial or pleural effusion. And the way to differentiate the two is a pericardial effusion or pericardial fluid will track kind of above the descending thoracic aorta. This is the descending thoracic aorta here. So pericardial fluid is closer to the heart within the pericardial sac, and then a pleural effusion will kind of track below the descending thoracic aorta. Here's a pretty big pericardial effusion. Notice how it goes all around the heart, tracks anterior to the descending thoracic aorta. Here's an image with both a small pericardial effusion within the pericardial sac, tracking anterior or above the thoracic aorta, and then a pleural effusion here. Some other possible findings with the ultrasound machine. So whenever the right side is dilated or enlarged, you can see that fairly easily on any of the views. And remember the rule of thirds. So when you're doing the peristernal long here, this happens to be abdominal mode, but this is the LA, the LV, the aortic outflow tract, the right ventricular outflow tract. The LA, the aortic outflow tract, and the right ventricular outflow tract should all be about the same size. So the rule of thirds. This particular image has some significant RV dilatation. Do we know what's going on? No. However, in the setting of hypotension or post-arrest, one thing high in the differential is pulmonary embolism. You also might see or hear the term D sign. So this is a parasternal short axis view. This is the LV, this is the RV. It's supposed to look like this. The pressures on the right side of the heart are pushing in here, or creating what looks like a D on the parasternal short axis view. And then you might see cardiac tamponade, and we're going to have several images coming up. But notice here, this is a big pericardial effusion or hemopericardium, unsure. It would depend on the presentation. But notice how the RV is completely collapsed here, and the RA is actually collapsing as well. Cardiac tamponade will result in no variation in the IVC, right atrial collapse, and RV collapse. So as the pericardial pressure increases, so you have all this fluid here, the pressure is increasing as either the effusion gets worse or the hemopericardium worsens. Your IVC will become plump. You'll have RA collapsing and RV collapsing. So the pressures out here are overcoming the pressures within the right side chambers of the heart. So on the right you have the subxiphoid view of cardiac tamponade, and on the left you have the parasternal long of cardiac tamponade. A couple things I want to point out. So we know this is a large pericardial effusion or fluid around the heart. LA, the LV, the aortic outflow tract. Notice how the fluid travels anterior to the heart. We see RV collapsing, and then we see the LV is pretty underfilled. This is a pretty serious situation that requires the tamponade and the fluid around the heart to be removed. Subxiphoid view, so the liver here, the RV up here, the RA, and again you see what's telling you this is tamponade is the RV is collapsing. Kind of hard to see the RA, but when you see RA and RV collapsing, that's when you know that the effusion is serious and significant. There's the parasternal short. Again, you don't necessarily need all these views to rule in cardiac tamponade. You have a hypotensive patient, fluid around the heart, RV collapsing, that is cardiac tamponade and pericardial fluid causing your problem. So parasternal short, this is the LV, the RA, the RV, the LV, and a little bit of collapsing in up here. Apical four chamber, so LV, LA, RA, RV. You're looking at the right side of the heart for collapsing. You see kind of the RA with collapsing in here, and hard to tell with the RV, but up here it looks like there's collapsing. Fluid all around the heart. So to review, where you start with the parasternal long at first, apex will be at the left side of the screen, so you'll either be at the 5 or 11 o'clock position. Turn to the right, 90 degrees, get your parasternal short, come down and do the apical four chamber, the subxiphoid, and one more turn to look at the IVC, inferior vena cava assessment. Now you will see this more commonly than the cardiac views be 180 degrees, so the heart is on the left side. Less important when you're looking at the IVC, but when you're looking at the heart, the standard is the standard and you need to do it the correct way. So here's the RA. Remember, the IVC flows into the RA. So the IVC flows into the RA. This is the liver here. This is your hepatic vein. So I want to make sure I stress that just because there's IVC collapsing does not necessarily mean that they are hypovolemic. Or if the IVC is large and plump, it does not mean they're volume overloaded. There are a lot of variances and things to be aware of. We won't go over all of them, but IVC is just another tool in your arsenal to suggest that RA pressures or RV pressures are either low or high. It's an indirect potential reflection of the right side of the heart, but its actual interpretation is pretty sophisticated and complicated. One of the potential pitfalls is when you're imaging the IVC in the long axis, depending on the plane or your cut, can make complete variances of what you're seeing compared to what's actually going on. So look at this cut is right on the center of the IVC. The IVC looks larger. If your probe is just over a couple millimeters, the IVC size is going to decrease quite substantially, and your variation will also change quite substantially. So you likely will see different providers imaging the IVC at various planes. The heart is always done the same way, standard. What's important when you're looking at the IVC is you need to make sure you're on the inferior vena cava. Sometimes the aorta can be confused, which we'll show images of later. And you're trying to find the hepatic vein, which is right here, where it dumps into the IVC. And you measure roughly 1 centimeter distal from that point, about 3 centimeters from the right atria. So somewhere in this area, you're looking for the IVC collapsing. On the left, again, this is the image is 180, but this is quite common to see it both ways when you're in the ICU. Here is a completely collapsing inferior vena cava. We're measuring around here. We're trying to catch the hepatic vein going into the IVC. The image on the right, notice how plump, and there's hardly any variation, suggesting this tank is full. However, in the setting of pericardial tamponade, as we discussed earlier, the right atrial pressures are high, you would have a similar finding. There are actual numbers and actual points of variation that I think are less important. In this particular trial, if there was complete collapse, so 100% variation, the patients tended to respond to volume. And there's a lot of different measurements and sizes to suggest what the pressure is. Again, I think these are less important. You're just kind of taking your global gestalt. I want to highlight here that there is a lot of variation and debate on how much collapsibility or distensibility, how big the IVC is. We are taking our information with a grain of salt. No one finding should be used to make clinical decisions. This is just one more piece of information you can have. So collapse 50%, this collapse 40%, variability 25%, and I will encourage you, if you're going to use IVC, to read more on the topic, because there's a lot of debate. Things change with intubated patients. We talked in the prior slide about how being on the wrong plane can actually change the size of the IVC quite significantly. One way to overcome that is to obtain the view in the transverse view. So IVC is on the left here, the aorta is here, and that's going to give you more of a complete view of the IVC. Here we see kind of the aorta here, the IVC here. You do want to watch out for the aorta when you're assessing for the IVC. This is the aorta. Actually, both images are the aorta. It's hard to tell on this one. We'll talk about that one. But here, clearly a thick wall here and some pulsatility. What you want to do is you want to catch the hepatic vein actually dumping into the IVC, and that'll tell you you're at the IVC. So this is the aorta. And I have to be honest with you, I didn't capture this image. The size here, it's small. It looks like the IVC, but is there also some pulsatility? And I don't know, just looking here, I don't see the hepatic vein dumping in. So I wouldn't use this particular image to tell me anything, and I would try to find another image, either go transverse or find the hepatic artery dumping into the IVC. One of the enemies of ultrasound is gas. In particular, with patients on BiPAP or who have gas in their abdomen, you may not see the IVC. When gas is in your way, or just another way to assess the IVC, is the transhepatic view, sometimes called the right alternative flank view. Instead of the gas obstructing your view here, you can move over to the side and assess the IVC. So the IVC will be closer. Remember, the IVC runs here, the aorta runs here, and the aorta will be more distal. So this slide highlights there's multiple reasons for a plump or dilated IVC. CHF, cardiac tamponade, restrictive cardiomyopathy, constrictive pericarditis, PE, pulmonary hypertension, low volume respiration, tricuspid regurgitation, tricuspid stenosis, and IVC thrombus. All these things can potentially make the IVC plump. While a large and dilated IVC may not tell you anything specifically, it can be used to help rule out cardiac tamponade. So if you have cardiac tamponade, you should have a large IVC that's dilated. So if you're thinking cardiac tamponade and there's no IVC dilatation and variation, while not perfect, it's unlikely that cardiac tamponade will also give you a small IVC with variation. Remember, IVC collapse is also very nonspecific. A lot of things can change how the IVC looks and its collapsibility. Severe dyspnea, the way a patient's breathing, all these intrathoracic pressure shifts can all change the IVC. I want to review lung scanning. I talk about this in the EFAST lecture. This can be done with any probe. And again, we are looking between ribs. We're looking at the lung. We're looking for the parietal and visceral pleura moving. Here's a rib here. Here's a rib here. This is rib shadowing. This is rib shadowing. We would be looking right here for lung movement. The image on the left is no pneumothorax, a lung that is up. The image on the right is suggestive of a pneumothorax. Remember, when you have parietal and visceral pleura moving, there's little calcifications on there. And you can see that up here. This is ants marching on the line, you'll hear. Some up and down lines called comet tails or B lines, and then some transverse lines here called A lines. Over here is suggestive of a pneumothorax. Remember, when the parietal and visceral pleura are not together, there will be no movement or calcifications moving back and forth. Now, M mode. Clinically, you do not need M mode to tell you that the lung is up or there is potentially a pneumothorax. However, for documentation purposes, this is motion over time. And what you're going to see is they call this finding sand on the beach. So you have the sand here, this little grainy area, that represents movement. Here, so you have the beach, the seashore, and then the sky here. They term this, and suggestive of a pneumothorax, the barcode sign. So for documenting, you can record your findings. So the way to rule in pneumothorax is you may hear a term called lung point. So here is lung point, and what you're seeing is the lung is moving here, and then at some point it becomes, there's a pneumothorax. So air separates the parietal and visceral pleura here. So this is actually suggestive of, or can rule in, a pneumothorax. I would not spend time looking for lung point. That just delays definitive care. However, if you're trying to quantify the size of a pneumothorax, you can use what are called zones. Now, these zones are labeled differently in different textbooks, but the concept here is what's important. So if you put the probe on the thorax up here and there's no lung sliding, you're going to ask yourself, well, first you're going to say, maybe there's a pneumothorax there. And then the next question is, how big is this pneumothorax? So the way to try to quantify that is to take it from zone 1 to zone 2. Clinically, you're just kind of going more posterior, and you are saying, no lung sliding here, no lung sliding here, no lung sliding coming from this way. That's a pretty big pneumothorax, versus if you just had no lung sliding here anteriorly, but there was lung sliding here, that could potentially be a smaller pneumothorax. Here's lung point captured in M mode, so barcode sign here, suggestive of a pneumothorax here, and then this captures the lung point on M mode. Talk quickly about A lines, B lines, and C lines. More commonly used are the A and B lines. Remember the A line, so the probe will shoot down sound waves, they'll hit the parietal pleura, they'll reflect back, you'll see this first line. Well, these sound waves keep on traveling. So this is an A line, this is an A line, this is an A line, and what it is the parietal pleura, that's called reverberation artifact. So sound waves are traveling back and forth, and you're seeing that as A lines. B lines, so these are the horizontal lines, also called comet tails, become more prominent when there's fluid in the interstitial lung space areas. And then also less common are C lines. We'll defer that discussion for another time. Here's the A lines again. And here's a patient with acute pulmonary edema. So there's fluid within the lungs here, producing more prominent B lines. I don't want to get into the details of how many B lines mean what, but generally, normal lung tissue, no B lines. As you develop more and more pulmonary edema, the B lines become more prominent. All right, now we will do a review and quiz. I'll show you some images and let you just think about what you might be seeing. So this is the parasternal lung, the LA going into the LV, the aortic outflow tract, the right ventricular outflow tract. What I see is a dilated heart with poor contraction. Notice here the anterior leaflet of the mitral valve. So if the LV were to completely empty, the pressure would be lower, and you would expect the anterior leaflet here to be touching the septum. Here's the aortic valve. So this is dilated cardiomyopathy. This particular image, I see an LA going into the LV, the aortic outflow tract. The anterior leaflet of the mitral valve hits the septum, telling me that the EF is good. Actually, it looks fairly hyperdynamic. This is the subxiphoid view. I see a lot of fluid around the heart. This is the RV, the RA. When I have fluid around the heart, I look at the RV and the RA. I look for collapsing, and it appears to be there. The next move, this is pretty convincing. However, if you were in doubt, you could look at the IVC, where you would expect a large plump IVC. This is a parasternal long axis view, or an abdominal mode. I see the LA going into the LV. The LV appears underfilled. This is the aortic outflow tract. And what really stands out is the right ventricular outflow tract is large. Remember the rule of thirds. This should be equal to this, should be equal to this. The right side is significantly dilated. This is a parasternal long axis view. So the indicator here is on the right telling me this is in cardiac mode. So therefore the indicator would have to be up and to the patient's right around the 11 o'clock position. No matter which mode you're in, the apex should be on the left side of the screen. LA, LV, aortic outflow tract, right ventricular outflow tract, anterior leaflet of the mitral valve hitting the septum. I see the papillary muscles coming in and out of view here. This particular heart is normal. This image is a little difficult to see. The LA, the LV, the aortic outflow tract, the right side of the heart. Because I see the anterior leaflet of the mitral valve hitting the septum. That's telling me the EF is probably normalish. I see something here. It's echogenic. Depending on the patient, this could very possibly be an echogenic fat pad, an epicardial fat pad. So this patient is an AFib, normal contractility. I think this is pretty apparent. This is the peristernal long axis view. We're in a cardiac mode. The LV is huge and dilated. The aortic outflow tract, the LA appears a little bit larger than it's supposed to be. The anterior leaflet of the mitral valve is barely fluctuating. There happens to be a pericardial effusion, which is small. Remember, pericardial effusion will go anterior to the descending thoracic aorta. Again, here's a normal heart. This is the peristernal long axis view. LA, LV, aortic outflow tract, right ventricular outflow tract. Another dilated cardiomyopathy, the LA, LV, aortic outflow tract, right ventricular outflow tract. Look at the mitral valve, it's barely moving, telling us the ejection fraction is likely quite low. Hard to tell if this is a pericardial effusion. If it is, it's small or trivial. Left atria going into the LV, the aortic outflow tract, the right side of the heart. You look at the septum, it's quite large. Remember, when you have hypertrophic obstructive cardiomyopathy, you want to slow the heart rate down and give them volume. And the reason you do that is you want the LV to be large and open, because what can happen is the anterior leaflet of the mitral valve here can become wedged in here. So this is Holcomb. This lung is up. We see ants marching on the line. Some B lines. There's another lung that's up. However, there's prominent B lines, suggestive in the area under the probe that there is fluid. When we have a weak heart and this seen on both sides, meaning the right and left lung, it's suggestive of acute pulmonary edema.